Good morning and welcome from Boston. It's as bad as it sounds, let me tell you. I'm sitting here, I rarely bring up notes to talk, but I'm like taking so many notes on the various comments made here. I think our slides would have been very different. Because Laura can't be here, I'd like my co-conspirators to please stand because you're going to be very actively involved in any questions and answers. Dixie, get up. Okay, just so you can identify to whom you can speak. Okay. We also take have great pride in the fact that we have the longest title, and it just kind of like falls right off your lips here. So the current landscape, and I didn't steal this from Francis, but I went further into what President Obama said, and I think this really focuses on the incredible need to involve participants. And I think he has said it more succinctly and more elegantly than I shall try. When our group got together, we, first of all, looked at the number of things that we were supposed to look at, and we came out with some principles and some basic needs. And the principles that we have, the incredible importance of participant-centric in virtually every piece of this. And one thing I've not heard here yet is we're talking participant as in the public. Another very important participant here are going to be providers. If we're going to really be looking at the interface, providers are also participants, so I think we need to bring them into the fold. We acknowledge that we live in a very heterogeneous healthcare delivery system. We have people who, even if they don't move, are involved in 3 or 4 different healthcare systems, and they move and they add another 4 or 5. And obviously, a basic principle is it has to be transparent, not only to encourage people to come on, but also to sustain their participation. So the needs, we have to be inclusive, multicultural. I think the last discussion on working off current cohorts, how representative are those? And does that actually get to the public we're trying to get at? Also, in terms of inclusiveness, is the disparate healthcare and access to electronic mechanisms. We need flexibility to accommodate all of the multicultural, et cetera. And this has to be resourced not only for starting up, but for sustainability. And I think Lord knows how much that will cost. An overarching challenge before we got into it is, because rules and regulations were part of our mantra, if you ever work on an IRB, we cannot approve a hypothesis. We have to approve a protocol. And so what is it? And whatever comes out, here are just some of the questions we would have. The details will definitely inform but the challenges and solutions are for participant involvement as well as for the rules and regulations. So I think, over the next many months, really coming down to a very black and white, this is our first steps, obviously they'll be changed over time, will be extraordinarily helpful. So we identified 3 broad challenges, which I'll talk about each of these separately, and we talk about challenge and then potential solutions. The 3 are managing the research-clinical intersection, engaging and sustaining new and affiliated. We use the term affiliated for those people in existing cohorts. Okay, so that's just all that affiliated means here. And engaging and sustaining, again, important not just in recruiting, but keeping them on board. And then the policies, regulations, and laws. So first, on the research and clinical intersection, we feel that the boundaries between clinical care and research are already being challenged. And in fact, we got rid of the term boundaries because we think there are already people on both sides of that river who are talking. So we would rather use intersection. And since I made the slides, we're using intersection. In terms of this, of these folks, everyone who is participating at that interface has to be involved. And again, I've already made the point, we have to have providers at the table. And we need to be clear to each of these various component folks what it is we're doing. The scope, the goals, return of results, huge issue, exactly what do we mean, and you can read down the list here. Our proposed solutions for the interface include developing, we use the word toolkits, but this could be seen as a resource, communications. We feel that participants and providers are going to need updated, easy to read, what's happening, what's in it for me, and what am I expected to do. Early on, an expert body, including participants and providers, to look at this interface. What are the issues? How best to deal with them? We need to provide transparent and continually updated expectations regarding coverage, payment for research tests, and what about the confirmatory tests or a potential therapeutic or diagnostic odyssey that results from a particular return of results. These are issues that we have difficulty with now. We will have to, it would be great to have resources and best practices for providers. This would be helpful outside of the cohort. I think this is something that's needed as genomics gets pushed out anyway. And to obviously regularly review what are the policies and practices, and to have this overseen by the aforementioned based governance group. The second topic, which really we spent most of our time on, is engaging new and the affiliated participants. I think one of the last questions, one of the notes I left to myself here, is value. What is the value for me? Why do I want to do this? And I know we keep talking about Framingham, but if you think about Framingham or the Nurses' Health Study, there's a feeling of membership. It's mine. I live in this zip code. I am a nurse. And how do we possibly get a decentralized cohort to actually feel like they belong? I think that'll be a huge issue. So in terms of issues for here, very important that we respect individual values and preferences and assume that those preferences are going to change over time. And again, the differences between people in cohorts, they may have more allegiance to their cohort, to their initial cohort, than to the big cohort. There's a lot of cohorts in that sentence, I'm sorry. Enable variable levels of engagement. Sort of really define what is minimum necessary to be part of this, and then what are optional. And to allow perhaps people to say, oh, in this year I am very engaged, next year I want to pull back a little bit. Would that sort of negate the importance of that person in the cohort, or could come up with potential practices that would allow that? Clear information practices, both for providing and for accessing information. This, I think, is a key issue. And a question was also brought up here regarding family members. Will this be, I'm involved, my family's involved, children of Pearl are involved? What happens? And is it a specific million number? And as people die off, we add to keep to 1 million? Or will it be a rolling, which be incredibly different logistics and different funding requirements for sustainability? Our proposed solutions, we have a few slides on this because we couldn't get off this topic. Again, governance. We need such active participant involvement, and it's going to be difficult. Participants are very heterogeneous as well, and to try to say, aha, here is our participant voice, impossible. For recruitment, obviously, if this is going to be representative of our population, we need to go beyond routine recruitment methods and really find people that we are interested in really creating the reasonable cohort. Important to talk with existing cohort participants. What has kept them involved? What is just too much work? What has worked, what hasn't worked? Look at cohorts that have failed, and what can we learn from them? Provide transparent information, and idea here is like the really basics, the few bullet points, here's what's happening, and for those people who want more detail, allow them to either hot link or here are additional resources you can go to. And again, these will need to be potentially geographic specific and obviously updated over time. I already noted the importance of, as you sign up, this is the minimum that we expect. Here's the ticket of admittance. And then, you can go and see previews or whatever as other options. And we obviously need to look at innovative ways of asking people if they are willing to participate, and also explaining to them what privacy and security will be provided. Maintaining involvement. I think this will be more difficult than recruiting. Obviously, social media and other innovative interaction modalities will be incredibly helpful. We need to enable remote. I can only get on the website at 2 in the morning. It has to be able to accommodate my timing of getting on the web. And also low-cost participation. We can't expect participants to have out-of-pocket, to be part of this, you have to own a smartphone. Won't work in a lot of situations. And also, the previous speaker also talked about the issue of multi-platform. We already deal with that. And also the gamification of data collection technology. Make it fun. What is in it for me? And, again, it'll help both sustain people in this. Return of results. The issue of providing individual level data is a hot topic. I think this is very important as one of the values to participants. Other values we thought of would be providing trend data. So people could go on the web and say, oh, this is what the cohort has done. And again, this could help the idea of involvement. And also for return of results, make sure that there's uniformity in resources to providers and participants in terms of how you're going to deal with the results that are coming back to you. What is the resource? If you're in an area that has no genetic counselors, and yet that is what everybody's doing in snowy Boston, I think that is potentially a problem. Policies, regulations, and laws. Obviously, we could spend a year on this one, but I think everybody would agree that the current oversight process for research is far from optimal for something of this ilk. We have state laws we have federal laws that are in disharmony. We have state laws that are patchwork quilt approaching to things. So it is an issue well beyond the cohort. We also acknowledge that the basic way to maximize privacy is just not to share any information. Clearly not where we can start from. So we need to look at where can we harmonize, what are risks that people are willing to take, how much can we truly say we're protecting things? And then the FDA oversight will obviously be an issue here in terms of return of genetic results and how those are going to be regulated. For proposed solutions for this last part of our task, I almost laugh as I say this, streamline research oversight that maintains protection. I mean, thank you very much, Dan. Clearly, this is something we all would like, even aside from the cohort. I think key to this is that maintains protection. And there are differences also between streamlining and harmonizing. Streamlining is sort of make it work more quickly, avoid duplication. Harmonizing is come to a common place. So I think there's room in both those to work. Hence, harmonize requirements for HIPAA and the Common Rule. Those of you who don't live in this space, there's different definitions of identifiability. So I think there's a lot that could be done there. Clearly address the liability protections for participating entities, particularly for providers. What do I do with this return of result where I don't really understand what it means? I don't want to do follow-up workup, yet I have a participant and the cohort governance committee that says, thou shalt work this up. I'm making that up. That's Francis's fault. Then, or even in handheld devices, participant reported things. How do you know it was the participant? How do you know it's valid? Do you have to act on it? Are you going to constantly have to be looking at your medical records to say, whoo, Pearl had a blood pressure of 200 over 150. Maybe I should call her because it was just reported on my little device. Establish standards for data provenance and rules for accessing. I think that, both in terms of accessing, actively accessing as well as passively allowing access, allowing participants to say, I want it to go here versus there. And I'm sure Sharon Terry will help us with some of these concepts later. Incentivize development of procedures within electronic health records. While electronic health records are definitely more common than they were even a year ago, it is far from a seamless system. Even within a big place like Partners, which has multiple entities, it is really the first time we're going to be able to communicate within our own hospitals, let alone outside. And as you look at these various electronic systems, they are still so actively moving and developing. What you bought may be different than the same thing that the people down the street buy a month later. So there's a lot of work that needs to be done there. Continuously, obviously, update the standards and the state of the art as things evolve. Ensure clean data transmission through mobile technologies. And I'm very anxious to hear about the mobile group later in terms of, what are the expectations, what's realistic, what's really pie in the sky. And then hopefully work with FDA to create flexible pathways for how we're going to deal with this information. So closing two slides, our opportunities, we think that this is an incredible opportunity to advance genomics into precision care, but the participants have to be the general public and the providers and the researchers. We think there's a huge opportunity for creating new ways of working at that interface between clinical care and research, and for really identifying how to engage participants, aside from the cohort, with PCORI efforts, with citizen research, citizen science. The call for having the participant being very involved from the get-go is key, and we don't know enough about that. So anything we can learn on that issue will not only help the cohort, but will essentially help almost every kind of research we do, and I think this could be a great spin-off. Develop new approaches for oversight that are responsive to this decentralized model. This will not be the first decentralized model. And obviously advance the learning healthcare processes. So in summary, we think that the challenges and possible solutions that we share with you here today are going to have to be re-looked at as it becomes defined. We emphasize the need to specifically address the intersection between clinical care and research, the need to employ wonderful new technologies, and I think we have a lot of possibilities there to sustain, not only to recruit, but to sustain, and the need to proactively look at federal regulations, state regulations, local policies and procedures that may obstruct wherever it is we want to go, and see what are the ways of hopefully coming to some agreement there. And we think this is an incredible opportunity for all of us, whether we identify ourselves as participant, provider, or researcher, and not only for the cohort study, but I think for research in general. And I will end with that, and here was our wonderful team. So I'll stop there, and I guess take questions, and Laura was not able to be here, so unlike the last group that was able to turf things, I guess I'm stuck. Okay.
David Ledbetter from Geisinger Pearl. I want to go back to your early comment about IRBs, and you made the comment they can't approve hypotheses, they can only approve protocols. And use of the term protocol seems to me out of date and disconnected with the notion of patients as participants and full participants and even part of the investigative team. So can IRBs approve relationships and partnerships in a learning health system model where you're defining the shared mission of improving health and well-being by either being a passive data donor or an active data donor and participant in the design and conduct of the research? Does it have to be a protocol, which implies an investigator-defined specific protocol?
Okay, what, I'm supposed to repeat that? I'm supposed to repeat that? You gotta be kidding me. I think what it is, is my comment on an IRB cannot approve a hypothesis but needs a protocol. Did I really mean specifically well, I guess how broad can I mean protocol? Is that fair enough? Whew, okay, I would have listened had I known I had to repeat it. I think when I use those terms, what I was saying is that we cannot approve a general idea. We need to have specific, what do you plan to do? So I guess, David, to yours, I would say, if you can say, here's how we're going to have passive and active data collection, data sharing, this is how we're doing it, to me, that would fall under the rubric of what I'm saying as a protocol. But it's the specificity. So I hope I didn't, confuse people on that, but it's more, hey, we have an idea. We'd like to study this drug in a whole bunch of people. Can you approve that? No.
But
We
just
need to
like
know who the people
Sec
are, what
brought
the-
up earlier, and we've already had a discussion about how specific do we want the endpoints goals of the project, and some people would rather not do that too early. I think in the same way, this whole notion of a learning health system implies we have a shared mission, we can define the nature of the relationship, and then let the participants work with us to define the specific protocols in a more dynamic, real-time way.
Okay, I think the questions, I think that's the idea is, could you, I'm hoping you're on the mic, and hopefully my answer will kind of say the question. I think in that case, you would kind of have a layering on. And my first question to you would be, at what point is that research versus just building relationships? And then you could easily say, we're going to have a review and approval of a concept of a database, be it a biobank, be it just a genomic database, whatever. And as it grows, you could come back in. So I think there's ways of dealing with that. And it doesn't have to be, here is our absolute final everything, and there is the protocol. I would see this as multiple iterations over time. And also, as I said, be careful, when it's not research, I mean, a lot of this is going to be organizational, and we don't need to see that. Oh, Lord, I pissed somebody off. Over here.
So I was Mike Lauer from NHLBI. I was really intrigued by your comments about engaging providers as well. I think there's extensive data that fewer than 10% of physicians actually participate in any form of clinical research, and I'm wondering what your group's thoughts were about making a dent there.
Well, we would love to make a dent in the number of providers that are involved, and I'm hoping that with, patient-centered outcomes research, maybe with electronic medical records, there's a lot of, hopefully a perfect storm of pulling people along. I think it'll be important to empower participants who will drag their clinicians along. So I think there's a lot, I think we are in a different place. And I think when you say, only, a small percentage of clinicians participate in research, that's often will you refer a particular patient to a particular protocol as opposed to, I think, a big systems issue. And I think the other thing it would be helpful, and again, in the last question and answer time, there was the idea of perhaps it would be a clinic. So I think there's other kind of organizational structures that you may be able to empower to pull clinicians along. Erwin.
The participant and provider paradigm that you pointed out is, I think, really important, but I want to add to that consideration of community. And in particular in areas where lots of communities are sharing space, a small space, we find that health is as local as is politics. Mm-hmm. And in particular, where the individual participants and providers' beliefs and attitudes towards what they think is valuable and what their preferences are shaped to a great extent by the interactions in their communities. So what I would like to propose and actually ask here is how can one bring the community into the dichotomy of participant and provider, because the community is actually shaping what is considered valuable, what is considered preferential, what is considered acceptable. And I think bringing community in on this will help a great deal with regard to sustainability and continued engagement of the participant and the provider.
I could not agree more. I don't have an easy answer to that. I think this is an issue also for research in general. I think an interesting way of looking at this in this big cohort study, could we learn something from the existing cohorts? Do they define that as a community? I realize you're also saying there's communities of healthcare aside from any research. But are there lessons we can learn for cohorts that have worked that we may be able to apply? But I think and here again, if you're talking a national cohort, how logistically, how do you possibly identify communities and then tap into those? And I think hopefully, as I emphasized here, the fact that they're also going to change over time. The community that I identify with myself today may not be the same one in 2 years. So I think that's a huge issue. I don't have an easy answer, but I think you're right, it needs to be at the table.
We have a question from the web also. An epidemiologist and genomics researcher at NCI has asked, what is the value for me, a sense of ownership? How to establish a centralized cohort where participants feel they belong?
Okay, everybody heard that. I totally agree with that. I think, as we said on the value issue, which was a word brought up in the last group, I think we have to have a reason why I want to sign up and continue on. And I think in the hypothetical that Frances gave, it was so positive. I mean, there were some positive feedbacks there that, her kids wanted to join. We don't know if they're going to allow them yet, but, her kids wanted to join. So I think that is imperative, and I think maybe there is something to learn from looking at current cohorts, looking, at child health study. Why did that fail? That was, huge, went all the way out there. What can we learn from previous things? But I agree. I think there has to be, here's my membership card, and I'm proud of it. Dan?
Oh, okay, now it's on. So it seems to me that actually one of the fundamental problems is that IRBs interpose themselves as representatives for the interests, the rights, and welfare of the participants. But isn't this an opportunity to do precision IRB work, which is to not interpose an intermediate representative when you can actually go to the person who has the values and the interests and could give the consent? And so is there a possibility of having a much more agile kind of IRB only when needed for populations who can't express their preference, and maybe that population doesn't even exist in this cohort. And so the old model of you go through the IRB to do science might not even apply when you can go directly to every single participant and get a very finely granular and contemporary and right up to the minute awareness of what they want to do, as opposed to they sign a piece of paper and we're off and running for some months or years. I'm sorry, Dan Macy's on a work group you're going to hear from shortly.
I think there are potentials that we have to look at in terms of what is the role of the IRB, particularly when participants are more in control of their data, and I'm going to allow this one to have it and this one not to have it, et cetera. I think it also requires an incredibly savvy participant. And I think for the IRB role, we rely extraordinarily heavily on researchers to also identify the populations, what are the particular risks and benefits to the various populations. So I think it's not just the IRB saying we're there to, protect that, be that individual or community. We rely also on the input of the people developing the protocol. And I think one thing that hopefully is going to improve that, but both the information the IRB gets as well as investigators, is embedding participants as part of the research team. I think we've done a very poor job of that, so I applaud that. We all know that there's this advance notice of proposed rulemaking for the Common Rule, which has been out about 3 years, that proposes a number of big changes, such as if the only risk is informational, it really puts it down as what they call an excused category of research. So I think there are potentials around here that, for the sake of time and also the fact that many people are listening, I'm not going to go into more detail and get myself in trouble. But I do think there's opportunities we need to look at, and the world's a different place than it was, even 2 years ago. Oh, I get to pick? Oh, okay, way in the back. Sorry, everyone else.
Hey, George from Regeneron again.
Oh, you had that bad question last time. Had I known that, why did I pick him?
Well, they ignored me last time. Maybe you won't. But I thought that was a wonderful presentation.
Thank you very much. Bye.
That wasn't a question yet. That was very comprehensive about identifying a lot of the issues. And as you said, all of these issues, just take a simple one like you want participants, or we like to call them volunteers, and you want them to be obviously informed and actively involved in the whole process. And one of the most basic things is the informed consent. And we've actually looked at the informed consents, in fact, of several of the cohorts that are involved here, and they are so outdated that they are irrelevant, and they can't even be considered as being used here. So I hate to sound like a broken record, but I'm going to ask you to intersect and harmonize with the previous workshop that started with this whole assumption of using ancient cohorts and bring them together and immediately getting near-term findings and so forth. But how do you see all these issues that you brought up that seem like they're all very important issues, they're very new types of issues involving as David said, whole new ways of trying to engage with patient volunteers, participants, whatever you want to call them. So how do you see harmonizing your issues and problems with the assumptions of the previous workshop about engaging these old cohorts and trying to start with them and bring them together?
Okay, in my last 10 seconds I have here. I'm going to have lunch with them. That's my answer. No, I think you're absolutely right. I think, though, the key is we're throwing around the term cohort rather liberally. What is going to be important is to say, are any of these cohorts actually generalizable into a larger cohort study? You're absolutely right. I mean, in some of these cohorts, we have consent forms that were there before DNA was discovered.
And I heard somebody mutter reconsent. We've looked into that. It's far more expensive to try to reconsent patients than to start from scratch.
Right. So I guess what I would suggest is look at, a handful of existing cohorts, see is there enough commonality and potential gain to make it worthwhile, or a la, I think the other question that you asked earlier, should you just start with everybody anew? And I personally have some preferences on that, which would be to start anew. But I do think we do have to do due diligence on the cohorts themselves and to see, what is their engagement, and bring cohort members in. Would you see this as an added, I'm already a member of this, I only want to study that disease and forget you guys.
I agree completely.
Yeah.
That there's enormous
That's why I
value.
called on you.
I think there's an enormous value. I think there's enormous value there in terms of that type of learning. I agree.
Okay, and just for future speakers, it's George back there. He's second from the left. Don't call on him.